And now on WRS, Michael McKay with the McKay Interview.
Hello everyone. Gradually the lockdown is being unlocked, our confinement is less restrictive, our freedoms are being restored. Thank God. But we still have to be careful, or to use the recent word of Britain's Prime Minister, alert. Today, the 21st of May 2020, I continue my mini-series during this time of COVID-19 to try to cast a light on what is really going on and to raise my and your level of understanding of its many complex aspects, especially those less frequently reported. I mention the date because events can unfold quite quickly. I'm delighted to have as my guest today a person readily acknowledged as one of the most prominent contemporary epidemiologists in the world, and someone who knows Geneva well, having spent 22 years at the World Health Organization on secondment from the Centers for Disease Control and Prevention in Washington, D.C. He now works in London, although he told me this morning that he's actually speaking to me close to or in Geneva via Zoom. Professor Dr. David Heymann is a man of vast experience, dating back long before SARS and the Ebola epidemics. He was Chief of Research of the Global Program on AIDS at the World Health Organization, founding director of the Program on Emerging and Other Communicable Diseases. He was the Executive Director of the Communicable Diseases Cluster and the head of the Global Response to SARS. And then finally, which is around the time that I met him, the Assistant Director for Health and Security at the World Health Organization and the Director General's representative for polio eradication. He's worked in all of the world's hotspots of infectious diseases, and nowadays he's Professor of Infectious Disease Epidemiology at the famous London School of Hygiene and Tropical Medicine, as well as head of the Centre on Global Health Security at Chatham House. That's the celebrated Royal Institute of International Affairs in London. I'm pleased to renew acquaintances with him after many years, even if only via Zoom rather than face-to-face. Hello, David. Thanks for making time to be my guest on the McKay Interview. It's good to see you again.
Thanks very much, Michael, and thanks for that kind invitation. I see I forgot to tell you to go light, but in the future I'll remember that I don't like these long introductions.
Okay, I remember that. Well, that's a good, you've opened up for a second invitation, David, so that's very good. David, listen, I've got more questions than our 15 minutes will allow, but I'll dive straight into it. Many of us will have listened with great interest to the words and rhetoric of the virtual World Health Assembly, which finished earlier this week. With your knowledge and experience of the USA Health and World Health Organization scenes, as well as your deep involvement in the COVID-19 pandemic crisis in which we're in now, what's your view of what we've been seeing on our TV news screens between Washington, D.C. and Geneva?
Well, you know, I think what's really important, Michael, is to understand that WHO has a political arm and a technical arm. And the technical arm at WHO has been performing as it always has, providing a place where people from around the world can exchange information and understand what's going on in disease outbreaks. This has been especially true in this outbreak, where because of this global collaboration, WHO has been able to advise the world very rapidly on the virus, on the epidemiology, and also on strategies that work and strategies that don't work in taking care of patients and in containing individual outbreaks. So the WHO is alive and well and continues to function as it has most times in the past, although there have been difficulties, for example, during the West Africa Ebola outbreaks a few years back.
Good, thanks. So essentially we should take what we see on the TV screens with a pinch of salt and let the technical people get on with things behind the scenes.
Well, that's clearly what's happening now, and I hope that will continue, yes.
Okay. What's your current assessment of the current status of COVID-19 across the 5 continents? Its distribution, its spread or reach, whatever the technical word that you use for it, its rate of affliction and affection. If my numbers are correct, it's about 4.7 million cases and over 300,000 deaths. And it's someone with your experience, are there any surprises? Is there anything that you see in the data with your highly trained eye that encourages you, puzzles you, or even makes you wary about the future? Wary, not weary, about the future?
Well, you know, with all new infections, and this is a new infection to which humans have never been exposed before, there's a big learning curve to understand what's really going on. And so the number of deaths is probably fairly accurate because deaths are hospital admissions or in the elderly care homes, and they're the ones that are counted best. So I think that we have a good estimate of what's going on as far as mortality. But what we don't understand is what the case mortality ratio is. That is the number of cases that have died over the total number of people who have been infected. And we know that there are many, many cases that are very mild that never come to the attention of the medical community. And so we have a skewed view of this outbreak with the 300,000 deaths that you mentioned. We just don't know what the denominator is for that number of deaths, how many infections have really occurred, and therefore how serious really this outbreak is compared to other outbreaks such as influenza, which occurs each year.
And is that a function of this tracing and tracking that we hear so much about?
Yes, it's a function of the strategies that different, that's right.
Yeah,
it's a strategy, it's a reflection of the strategies that countries have selected. Some countries are only testing people who are quite sick and enter into a hospital. Others are testing contacts. Others are doing almost nothing. And so it's a reflection of how much testing a country does, how many actual infections there are. But that doesn't really affect the number of deaths, which is a more solid indicator of what's going on.
Okay. My next question leads on from that, David. As I follow the progress of this COVID-19, I'm often reminded of those remarks of Donald Rumsfeld, the erstwhile US Defense Secretary. He talked rather enigmatically at the time of known knowns, known unknowns, and unknown unknowns. I think the expression actually predates him, but it doesn't matter. Are they expressions that you use in your profession, whether formally or informally? And what still do we not know about COVID-19 that frustrates or even worries you? Does the volume of research, just to add to that question, does the volume of research, like for example the recent grand Operation Warp Speed that was announced as a rapid vaccine development by President Trump just a few days ago, does that encourage you? Are you optimistic that a vaccine or antiviral drug will be found soon? And if so, why and when, David?
Well, we know a lot about this virus. We know how it transmits from person to person. We know that it does create an immune response in people and that there are antibodies that can be detected. But we don't know whether those antibodies are protecting humans who get infected from a reinfection. And we don't know how long they might last if they do protect against reinfection. We know from other coronaviruses that antibodies are produced, and there are 4 seasonal coronaviruses that inhabit humans and that cause common colds each year. They cause a weak immunity, but you can be reinfected the next cold season with the same virus. So that's the problem with developing vaccines. We don't understand a lot about immunity, but there are many, many research projects going on, over 100, I believe, looking for a vaccine using various technologies. Some of those vaccines are trying technologies that have never before delivered us a vaccine, such as technologies which employ messenger RNA, which is a part of the virus that's incorporated into human cells, reproduced, and produces the spike protein, which is where the immune response is most important. So this is a new technology. There are other technologies based on standard measles vaccine technologies or others, and all those are coming together, and hopefully there will be a vaccine. But once there is a vaccine, then we have to make sure that it's equitably distributed throughout the world.
Just to quickly add on from that, is it fair to assume that these scientists who are working on these things are talking to each other, or do they tend to guard things fairly close to their chest because of confidentiality?
Some of the companies have decided to work together. Others are still guarding that confidentiality. And many of the groups that are developing vaccines are very small biotechs, which are just startups. And so they depend on making a profit from what they're developing, so they're certainly more cautious than others. But all in all, there is some collaboration, but not a lot of collaboration. I think what's more important is to have collaboration and distribution of an eventual vaccine if one is developed.
Thanks. My guest today is Professor Dr. David Heymann of the London School of Hygiene and Tropical Medicine. David, not to make this too personal, but from my point of view, what about race and ethnicity? I have a personal interest in this because I'm West Indian by birth from Jamaica, and ethnically a mixed bag, a Heinz 57 variety, as indeed are many of us from the West Indies. And on top of that, David, I'm over 70. So my question to you, Doctor, is am I vulnerable and at particular risk, because I don't feel it, but maybe I'm just ignorant of the particularly dangerous new world that we now inhabit? What do you make of the debate about race and the susceptibility of some racial types to be cut down prematurely by COVID-19? There does seem to be some circumstantial evidence.
Yes, and certainly that's being investigated. I actually chair a research group for the Department of Health in the United Kingdom and the UKRI, which is the innovation department of the government. And the most recent call for research that will be completed within the next 12 months was just for research, trying to see what the links may be. Right now, we understand clearly that people over 70, and especially those with comorbidities, and that includes obesity, diabetes, it includes lung disease, it includes heart disease, a whole series of comorbidities do increase the risk of serious illness and death. And in younger people, comorbidities also increase that risk. We also know that every age group is at risk, but the greatest risk is, unfortunately, Michael, for those over 70 where you and I fit, and those who have comorbidities, which we may not fit.
I'm not sure whether you cheered me up or not on that one, David. But look, you've led into the next question because you use this word that comes up so often, risk. When I watch press briefings on TV or read reports in the press about this present pandemic, I see words like danger, risk, safe, safety used frequently. But these are relative words and not necessarily absolutes, aren't they? At least from a public health point of view. The non-experts like me, most people listening to us now have to rely on people like you to guide our policymakers and political decision makers in the right direction to make the right policy decisions. So in that context, what words of advice would you give regarding the reopening of schools, the reopening of shops, the air travel and hospitality industries, where people, usually strangers, are in close proximity to one another, and to make our lives tolerable again? So just in summary, give us an idea of what is acceptable danger, what is acceptable risk, and what is acceptable safety, David?
Well, Michael, every individual has to make his or her own risk assessment based on their understanding. So it's very important that people in general understand their risks, understand also how they can protect themselves and protect others. Protecting themselves is physical distancing, is social distancing, that means staying away from crowds, and is also washing hands in case they've touched a surface which is contaminated with droplets from an infected person. On the other hand, they can protect others by being sure that if they are sick, they self-isolate, and they wear a mask if they can't physically distance from family members, and especially the elderly. So people have to be underpinning the response. The government then makes its own estimations of when it's safe to open certain sectors. And in Asia, what they've learned is that they can do a circuit breaker type opening and closing.
What's
and they
that?
do call these circuit breakers,
Just
which
explain.
means, for example, in Hong Kong, when students came back from their holiday in China after the school reconvened, they found that they were more infected than the general population. So they immediately shut down nightclubs and areas where those students go, and they're keeping them shut for a couple of weeks until they're sure that COVID is no longer a problem in those who are young and returning from China. Then they will open up that sector. The same has happened in South Korea with the nightlife sector when they identified people who were infected in that sector as well. So circuit breakers may become the norm when sectors are closed down and then rapidly opened again when the risk is less.
David, many, many thanks for making time for me and our listeners and for answering all my questions so carefully and so thoroughly. My guest today has been Dr. David Heymann, Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. Thank you so much, David.
Thank you, Michael.
That was the McKay Interview with Michael McKay. And don't forget, you can hear that interview again on our website, worldradio.ch.